probably good to go if you like, Sujith.
Okay, fine. So good afternoon, everybody. Welcome and greetings from London. So I have two cases for presentation today. So the first case is a preterm baby. So this is a 27-weeker weighing 790 grams, was born early because of maternal PET. Mother received 2 lots of steroids, magnesium sulfate was given, and Abgas of 810, received total dose of surfactant was 455. This was at a local hospital, and the team were unable to wean the respiratory support, and therefore the baby was transferred to us on day 3 of life. Yeah, so that's the X-ray, and these were the sort of gases that the baby had on pressures of sort of 25/4. So that's, the baby did need sort of high pressures to maintain tidal volumes of about 5 per kilo, needing about 50% oxygen, and the gases were sort of just about acceptable. So I inherited the baby on Monday, and on Monday, this baby, there was some pinkish secretions from the endotracheal tube over the weekend, and then had a pulmonary hemorrhage on Monday, and managed with slightly higher pressures, blood products, and these were the observations. And clinically, on examining, the heart sounds appeared, there was no murmur, and that was the blood pressure. This was the X-ray that was done after the hemorrhage. Yeah. So this is the first echo. Okay, so this is the echo that I did after the pulmonary hemorrhage. So you can see, obviously, in the 2D picture, left atrium is bigger than the right side. Reasonable good contractility on color. You can again see the same thing. And short axis view, you can see, so there is a good sized duct, which is almost as big as the branch pulmonary arteries. So, so one of the things was, so I have this baby who is 9 days old, 27-weeker, who's had pulmonary hemorrhage, and who's needing about 40 to 50% oxygen. And I was thinking, so do you treat this duct or not? And I want to see, so for my colleagues, would you treat this PDA? Or would you need more information? I just want to see what you would have done.
Possibly a bit more information about the duct, if you have.
Okay. So the information. So I can give you the information. So let me see if I got my next slide. So some more information. So pulmonary wave D wave was close to point. It was 0.48. LAA ratio was elevated, so it was 2.03. There was evidence of ductal steal. So this is distal to the duct, and it's all reversed. Yeah. Let me see if I've got more information. So there you go. So LAA ratio 2.03, pulmonary vein velocity is 0.5, supranormal cardiac output. You have reversed and diastolic flow, evidence of left-sided dilatation. So Z scores are well above 2. And you have a 3 millimeter duct in a baby who weighs 740 odd grams. Non-restrictive, clinically, lactates holding, no murmur, and that's the blood pressure.
So, I mean, by definition, this is a significant duct, not only echo parameters, but clinically to the extent that has caused pulmonary hemorrhage, isn't it?
Yeah, absolutely. So yes, so you would treat, isn't it? Yeah.
Yeah, I think Anai want to say something.
Thanks. Sorry, I personally would not treat this. I mean, obviously, you know, the duct is quite variable practice in different units, how you do, and depending upon your unit culture. I mean, to be honest, at George's for the last 15 years, we have not treated anyone more than 27 weeks gestation. This
is exactly why I asked, Annie. So usually I know if I were to refer to the literature, with a baby,
if she comes, I want to see him. Sorry, was the flow totally right, left, or I mean left, right, or
Yeah,
bidirectional?
No,
Totally.
the flow is fully left to right.
Okay.
Yeah. So this is the dilemma. So if I were to go and read the literature, and there is clearly evidence to suggest that in the first 2 weeks, there is no evidence to, there's no benefit in treating. But I think in real life, you are sitting with a baby like this, needing high pressures, who has pulmonary hemorrhage, it becomes a bit tricky. So this is what I did. So, I mean, I ended up treating the duct. Yeah.
Yeah.
But if you look at more, so if people are using the Iowa score, so the modified Iowa score, this baby will score above 6. Yeah. So these are things that this baby was scoring. And so I know the Iowa scoring is done at sort of early on. So less than 26 weeks, they're doing at 12 to 24 hours. And more than 26 weeks, less than 28, they up to 7 days you're using it. But for people, I know some of you all use the modified Iowa score, but if you were to follow that, yes, you would. So let's see. So this was pre-treatment on top. Yeah. So this is, the baby had some feed intolerance, so paracetamol was used. So this, the ones below, after 12 doses of paracetamol, yeah, on day 3 scan. So you can see the left atrium does look a bit smaller, yeah. And the duct from 3 millimeters, they've gone down to 0.8 millimeters. So there was an improvement, yeah. And if you look at pulmonary D vein, velocities have dropped, LAA ratio looks smaller, and this is impressive. So the distal to the origin of the ductus, now you have forward and diastolic flow. And if you were to look at the parameters, so post treatment, LAA ratios dropped to 1.6. The pulmonary vein D vein velocity is on the low normal side. Cardiac output is in the normal range. There's no more ductal steal, and the Z scores have normalized. And obviously the PDA is much smaller than what it was. Lactate, like I said before, has been fine. And this baby's creatinine was always fine. Clinically, so this baby had an unplanned extubation and then got re-intubated, but after 12 hours was then extubated, and these are the gases post-extubation. You can see the gases are better slightly. So, I mean, it is a little bit of a dilemma, and I know in practice, the vast majority of babies who need treatment are usually less than 26 weeks, but then you do have the odd baby who's a bit more mature who may end up with treatment. And it is tricky. So other systems, so serial head scans are all normal, babies established onto full feeds and is building up feeds. So that's all I had for that case. And I want to see if, before I go on to the next case, are there any comments, questions, things that people would do differently? The question I had, the dilemma I had is, oh, I know it's a slightly more mature baby, but you have highish pressures and this baby is having these episodes of pulmonary hemorrhage.
Yeah, I think it's a very interesting case, Sujith, and I suppose you have to take each patient differently,
exactly.
And it's not like a cutoff blanket management for a cutoff below and above certain gestation, and that's the beauty about the hemodynamic assessment. You just do and look at bedside management and also look at the patient on echo as well. And this lovely case demonstrated beautifully that you have changed the management and changed the outcome. This baby, suppose that you left the duct open like this, you would have probably another pulmonary hemorrhage, and you probably left the baby on the ventilator for a longer time. I appreciate that it's different opinion in different centers and different practices as well. But yeah, I think each patient probably should be treated differently.
Absolutely, absolutely. And it's tailoring, and it's sort of personalized medicine, and it's tailoring it to that particular patient. I don't know. I don't know if the outcome would have been different had I not treated and just let the baby linger on a bit more and then extubate. I don't know. But at least from the images that I see, when I see the hemodynamics of it, I see that there is evidence of excess pulmonary blood flow. I mean, at least in theory, it should be contributing. I don't know.
I think Maha, Anai, and Umaima have questions.
Yeah, please. I can't see anybody's hand, so please go ahead and ask. Yeah.
Umaima, do you want to go? I can catch up after you. you met.
Yeah, no, it's just a comment. I agree with Mahmoud and the rest of the team that I would treat this baby because clinically we have pulmonary hemorrhage, lung fields appear very congested, and also all the parameters look very moderate to severe PDA. Just the question, was there any Doppler for the superior mesenteric or cerebral arteries?
So routinely, so superior mesenteric and celiac artery, it was absent and reversed. I routinely don't check. I check the anterior cerebral. So for this baby, I didn't. But I didn't check the anterior cerebral, but the gut vessels were reversed.
Were the worst?
They were, yeah, absent and reversed.
Okay.
Any other questions?
Maha?
Hi, thank you, guys. I just wanted to ask when one of the previous speakers, sorry, because I don't know very many of you, who said they wouldn't treat. I just wanted to ask, what do you all mean when you say treatment? Because we certainly in our unit are also very averse to giving any sort of non-steroidals or paracetamol. But we do treat the duct, so we assess them as you've mentioned very nicely there, and you can obviously do all the things like increasing the PEEP and making sure you're not giving too much fluid or giving any medication that can help open the duct. And we have, in our experience, and I think from the literature as well, the natural history is for this thing to close, isn't it? And very many preemies don't close it. We just haven't seen a great success with paracetamol, maybe because we are so averse to using it, but we very much personalize it by, we really pick and choose the babies that we give it to. And for instance, just the last two babies that we gave paracetamol to in the last couple of months, one of them, the duct, you could see as on the second or third day of treatment that the duct was smaller, but then it just stayed that way. So it's still hemodynamically significant. And the baby's actually very well. She's still on the bench. She's a small 24-weeker. So I don't know how much benefit we've accomplished. And the other little person who was a couple of weeks, something like that ago, who we gave paracetamol to, actually maybe I think a month or so ago, the duct did close and then it reopened when the baby was septic. And in fact, the baby was very sick from all sorts of other things. So I just think, depending on your experience and how old you are, you start thinking, gosh, I don't know if we're doing anything useful by giving these kids treatment. Certainly, I'm old enough to remember indomethacin and brufen, and we did, I think, a lot more harm with those. So we completely stopped using them. But yeah, we haven't had a huge amount of fantastic experience with paracetamol. But we certainly don't say we don't treat ducts, because we treat them with non-pharmacological measures, you know what I mean? So I don't know if anyone else does the same, or if we're just on our own here.
Well, I agree with your views. Our unit, so we have data going as back as 1990s, and we just looked at the last 30 years of our data, and we've just become more and more tolerant. So around 2015, we treated around 20 babies out of 100, and now we treat probably 3 100. I mean, we currently have a baby exactly as you were born at 25 weeks gestation with pulmonary hemorrhage, with quite impressive echo, and there's always this wanting to do something looking at the scan. But there's still a view out there that PDA is a manifestation of prematurity rather than it causing morbidity with preterm. I understand we would want to change the physiology. But this kid, which I was referring to, we didn't do anything, had pulmonary hemorrhage, settled, and got extubated 4th day at 25 weeks gestation, and that had closed spontaneously without doing any intervention.
Thank you. You sound like you do the same as us then.
Yeah, I mean, over the years, it's just we have become so tolerant. I mean, after a week, our response rate is 20% for brufen. Paracetamol, we have started probably 9 months to a year ago, and I have not seen any response yet. But that's probably because we treat late rather than anything else.
Can I say, Anne and the group in Wales, can I ask, the paracetamol, are you giving oral or IV?
Both.
Both. Because what both of y'all say are absolutely right, and it sort of is very much mirrored in the research that is coming out, in that conservative approach is more and more commonly followed now. So the active treatment are actually dropped. And one of the things is, with that, people are sort of treating a bit later. And one of the issues, especially with ibuprofen, is the dosing, because I suspect majority, the most common dosing is 10-5-5. And if you look at the work that Souvik Mitra has done, that's been published in JAMA in 2018, when he looked at the different dosing, the best dosing, which he found was the high dose.
No, we use higher depending upon gestation. So second week, third week.
What dosing do you use, Ane?
So we go up by 2.5, so 12.5, 7.5 second week, and higher third week.
So the dosing
based on same work that you quoted.
Yeah, so the dosing that that study found, which was supposed to be the best, that works the best, was 15, 7.5, 7.5. Oops, I don't know what, something's coming on the screen. Was 15, 7.5, 7.5. And his personal practice, which I heard in the PDA symposium, was for less than 5 days, they use 10-5-5, and beyond 5 days, they use 20-10-10. So, I mean, the dosing does play a role. But one of the things is to say is, if you look at the PDA Tolerate trial, the subset of babies who were not recruited because of lack of physician equipoise, who were treated early, there was an increased survival in that subset of babies. So that is one signal. And the other signal where, treating the PDA early does help to an extent is, I don't know if you read, there was a recent paper from the Toronto group where one hospital used a conservative approach and the other hospital did not change the practice. And the one that used a conservative approach, there was much higher incidence of BPD. So I don't know. I mean, if you look, the data, the evidence is lacking, and I suspect it partly may be due to the fact that there is no consensus in what a hemodynamically significant PDA is. There is no consensus in when people are treating, the doses that are used, and even the medications that are used, which by and far only treat sort of close to 40-50%, and there's quite a lot of variability, and that's not to not mention the genetics component that's there. So there are quite a lot of variables, and I don't know, maybe the pivotal trial will probably shed more light where you have definitive shunt elimination.
Yeah, thanks, Sujith. I think Anne-Marie and Maha also has a raised hands. Anne-Marie?
Hi there. Can you hear me?
Yeah.
Yeah, great. Thanks. I just joined on my phone slightly late. And I missed the presentations, but I think I got the gist of them at the end, and the conversation's very interesting. And I would agree, a lot about ducts is about managing the physiology, and you don't always need a definitive treatment. But I would raise a few points. First of all, you might manage some babies through pulmonary hemorrhage, but I do think we need to consider that some babies die acutely of pulmonary hemorrhage, and that is a huge tragedy that I don't think is picked up on the clinical trials. And it's partly because some of these sickest babies never get into them. A point that the PDA Tolerate trial, which we led on in the UK, highlights from the clinician bias paper. And I think we really need to think about that group, and it may be about adjusting their circulation, but sometimes I think without closing that shunt, you can get nowhere. But very much, it's not a one-size-fits-all treatment. And if we apply Brufen to all babies or indomethacin to all babies, of course, we won't see clear benefits. I think the other thing about the trials is the trials have been exploring exposure of the baby to a drug and not exposure of the baby to the shunt. And if we look at the sub-analysis trials of things like Trio Capi and Tolerate, you'll see that the babies whose ducts don't close, even with very careful risk adjustment of all the other factors that might be applying them, are ending up with much more severe BPD. And it's severe BPD is an outcome which matters, not just are they on a tiny bit of oxygen or not, it's the baby's stuck in high flow and stuck in ventilators. So I think we need to think about that as our outcome, and also, is it the exposure to the drug or exposure to the condition we measure in clinical trials? And I think by not actually measuring the condition, because we didn't always have good echo data on what's happening to these babies in the trials, I think a lot might have been missed. So I would caution slightly a huge enthusiasm for throwing away ductal management because the trials don't show obvious benefit. I think there's harms from not treating there when you look, and some benefits from early treatment when you look at some of the other outcomes from trials, as well as the fact we know the reduced pulmonary hemorrhage and early hypertension if you do treat the duct. And I think the final point I would say is from our unit, there remains always hot discussion about what we should do about our ducts or not. But one thing I've noticed, that just within our own department, by taking away ducts relatively early on, not necessarily in the first few days, except for a very high risk group of babies, we've kind of abolished neck. And it might be other things like increasing our breast milk, but we are getting steadily better outcomes across a whole range of outcomes since we kind of changed our policy from being a unit that didn't treat and only had duct ligation to putting in a standardized approach. Duct ligation, by the way, had largely gone. So I feel slightly more optimistic that it's about looking carefully for the right babies and early targeted treatment and a kind of precision-based approach, and that there is a role for duct treatment. Sorry, I've said enough, but
thanks,
it's all very interesting.
I just to add to that, I think there is also one kind of morbidity not many of us pay much attention to. It is a chronic pulmonary hypertension in those babies who actually have ducts left untreated. And you know, McGill University in Canada, Gabriel Altit, his unit actually, they don't treat ducts, but they presented recently in the last past meeting, they noticed increased incidence of chronic pulmonary hypertension in this age group.
Yeah, that's right. And there's lots of qualitative data coming out of the States of units that have moved away from duct treatment and find their treatments are worse. And that's really interesting because it conflicts with the clinical trials. And I think it just shows the complication of getting the right babies and what it is we're actually measuring in these trials, where we've got a treatment that isn't terribly effective, depending on how much is given and when it's given. So I think we're measuring the wrong thing. And I can also say that the babies we see coming into our unit from around the country with NEC and SIP are the babies with big open ducts. A lot of them have had paracetamol and none of them have ever had brufen. So I don't know what's happening to the babies that don't come, but certainly brufen isn't causing problems that we see coming in.
And
so I find that reassuring.
Do you routinely screen babies, high-risk babies in your unit?
Sorry?
Do you routinely screen high-risk babies in your unit?
Yes, we're trying to. We're trying to introduce that with a NERS protocol, because the other thing is that, you know, you can see from the people who look at NERS that again, the long-term outcomes in brain growth are poorer in the babies with low cerebral perfusion. And there's no doubt low cerebral perfusion and ducts sit hand in hand. And of course, the argument is always, well, it's not the duct that's causing it, but I think if you take a physiological and sensible based approach, you need to put all these things together for individual babies and look at them and get a balance of risk. So yes, we're trying to look at the high risk babies under 25 weeks very early on, and the babies under 28 weeks within the kind of first 3 to 5 days. But we're still firming it up, and I would really like to see it something that we assess sort of multimodally along with NERS and the baby's condition and the baby's phenotype and the baby's antenatal history. You know, the babies that have had surfactant and are near seem to me, they're very tiny, seem very high risk for pulmonary hemorrhage, and you just need to think about them.
Unlike of antenatal steroids as well.
Yes, it's a whole story, absolutely.
Anne-Marie, can I ask, the comment you made about your incidence of neck coming down is interesting. How early are you treating on average your ducts? How early are you, when you screen, you probably will pick them a bit more earlier. How roughly, what's your median or mean age of treatment?
It's probably 3. It gets slightly later for the babies that are slightly more mature, your 26, 27 weekers, and it's possibly about 5 days for them. I'd like to get in after they're on some milk and their circulation looks stable, so I'm more confident about not adversely affecting their gut or anything. But certainly before we would consider starting steroids, so maybe about days 3 to 5. And we're really just experimenting with looking at the smaller babies very early on, and just trying to build a picture. But I feel I've had my my fingers burnt by sitting back in some a bit, and they're the babies that look like they've huge shunts, but they were well, and they're the babies that deteriorated very suddenly and tragically. But I think we're learning a lot just by looking at them.
Yeah, interesting. Are there any other comments?
Is that okay? Yeah, just when. So I personally, because I've been practicing too long and I've been through all the areas, you know, from treating everyone to treating none, and then probably in the last 5 years, like selective, like case to case. And I found that, like, as Anne-Marie, I think you explained that very, very well. I wouldn't be even being close to that. So yes, to treat early when there is hemodynamically significant PDA. I think Patrick McNamara and Afif El-Kofaj for the last 5 years, they've been like screaming to everybody, select your cases and treat. And this is actually what I'm trying to do, and many other voices with treatment. So there is a lot of evidence to go with treatment rather than not to treat the hemodynamically significant. I always have concern in every unit I go with the babies who are having very significant pulmonary disease with the element of pulmonary hypertension. And here, this is a major problem, because I can see some people, they are keen to close the duct where I'm keen to keep the ducts open. So how to draw a line here between closing the duct in such category of patients, because this is very, very serious things. And actually all the babies I've seen closing the duct in them with this context, they become very, very unwell.
I completely agree, and I'd be interested in others' thoughts. I think they're a really challenging group, and I think I often see them and think it's a tragedy they got to that point, because it could have been perhaps dealt with earlier, but others will say, well, how do you predict which baby is going to need it? And there's no evidence to give them early medical treatment. One thing that one of our cardiac surgeons raised once, which we don't practice, but I thought was quite clever, was if you've got a baby with an element of both pulmonary hypertension and a big ductal shunt, almost why don't you go in and sort of reduce it rather than close it? So it would be, is there a case there for interventional devices that shrink it? Because closing it completely can sometimes make things worse. I don't know. It's just, they're really complicated. And I would like to say best not getting to that point, but we still do.
But you agree we shouldn't try to close the duct in those category of patients? I
think they're dangerous, can be dangerous if you close them completely quickly. It needs really individualized and a kind of team decision. If you're going to do a surgical closure on them, they'll need really good intensive care afterwards. But it's difficult because they have a balance of diseases then. And maybe it's just about shrinking it. Anyone else's thoughts? I'm saying too much.
Sorry, Mahmoud, may I ask another question just very quickly? Anyone using the PI, the perfusion index in the saturation monitor, like if it is increased, probably this will urge it to check the ducts more, or is there any clinical value? Because usually on the sat monitor, we can see the PI, but we don't really pay a lot of attention to it. So.
Yeah, it's an interesting question. Yasser Saeed has published a paper about this and the correlation to duct significance. I can find it. I will try to find it and send it to the group.
That would be really useful. We have it in our monitors recently since we changed to Massimo-Sats, and it's ignored. And I think it was a really interesting thing to look at.
He said that it's quite correlating. If you have a widely open duct, then you will get lots of fluctuation that will increase the variability in the PI index. And then once it's, you can actually monitor the response to treatment once it's becoming less variable and the extremes are limited, then that means the variability is less and the treatment is successful. I think it's logical, but yeah, it's interesting concept. Yeah.
Yeah.
Sorry,
That
can
would
I
be
just
really
ask one
useful to
question?
look at.
In your unit, how many people do hemodynamic assessments? So we are the unit, we're tertiary surgical unit. We are 14 consultants and 2 of us scan. So what's kind of a working side of things? So if you propose to screen all the high-risk babies, is there any, how do you kind of get job planning and those kind of side of things sorted to provide service which is acceptable and agreeable to everyone?
That's $1 million question, and I think if you're asking me or asking Anne-Marie, for my unit we have only 2 people who can do that, and I don't know, Anne-Marie, it's probably you and Neil.
Yeah, it is difficult.
And Abhijit as well.
Yeah, so we only have a handful of us that can do it out of a team of 22, although that covers 2 bits of service, 2 units really. I've got to manage to negotiate a tiny bit in my job plan. I think the way forward for us is to establish what our practice protocol is, and we're getting there, but also to establish a training program so that we've got standards and governance. And then I think we'd all feel more comfortable bringing on other consultants who've expressed an interest. But I think that's our way forward, is having protocols actually established that you do want to look at these babies. The early hemodynamic adaptation must be important. It's not as important as lungs, it's just we can't see it. But then having sort of firm governance and training things in place, so it's sort of open to more people in the team, and people aren't scared, because as an institution and as individuals, you've got established training. That's the only way I can see it. I don't know what others think, if there are easier ways forward. We're so different from the States, who have full teams doing this.
Yeah, and any kind of resources, I think, if you want to develop something, it should be sustainable long term. Obviously, a lot of us will do it because of your own interest to start with. Yeah. As I was very enthusiastic looking for babies to scan rather than being asked for. But it's just having that, and every time you go, people ask you for the evidence, and that's where the challenge has been.
Yeah, and I think that's the role of our group, is just to spread the knowledge and help the training to progress, because I think it's probably relatively new here in the UK. More detailed hemodynamic assessment is, I don't think it's been there for long. So we're a bit behind Canada, but I'm hoping that we're going to progress quickly.
Yeah.
And Anil, is it you that asked the question?
Sorry?
The question about the personnel doing the scans.
Yeah.
I think one of the things which, see, in my unit, I'm the only consultant who does among 13 consultants. But one of the things I do is I have fellows, long-term fellows. I train them up. So I have now another fellow who's trained. It took about 8 months, but I have the echo pump simulator. So I do echo clubs and I train. And one of the things is to engage the younger generation. So the trainees, they're very interested. And if you have some sort of setting, it is getting them up to speed with it. And a lot of trainees have a lot of interest. I know it's difficult. Some of them may stay for a year and some of them may stay for 6 months. But I think slowly getting them exposed also will help. But there are consultant colleagues who are interested, which will always be the case. But if there are fellows who are there who are interested, you can include them also. And that will help.
Yeah, thank you.
That's amazing, Sujith. Right, so we'll let you go for the second case.
Yeah. So before can you see any? I can see some bizarre red lines on my screen. Can you see?
Yeah, would you like just to stop sharing and share again? That might just go.
I don't know why that's come.
Oh, I think it was my fault. It's very embarrassing. I logged on in my phone, as I tried to press buttons to get to the chat screen. I seemed to get a pen rather than a chat that wrote, and so I might try.
I'm just a bit wary if I share and if it doesn't work, then it'll waste everybody's time. Shall I just try and see if it's not distracting?
I'll see if I can get rid of them. Eraser.
Oh yeah, there you go. Thank you so much.
Oh, fantastic.
There you go. Right. Apologies. Live and learn.
No, thank you so much. So moving on to the next case. This is a baby. So this is a different case. So different flavor. So this is a term baby, born at 39 weeks, weighing 3.19 kilos. Good Apgar scores. Mummy had GBS colonization and received intrapartum antibiotics. This baby had 12 hours of observation in the postnatal ward, and those are the observations here. So all normal, and was discharged after that, breastfeeding well on day 1. The family then present on day 8 of life with maternal concerns of fast breathing, was admitted. So on the history, there's no history of intercurrent illnesses in any of the family members. There's no history of significant medical illnesses. These were the observations. So the temperature is absolutely normal. Heart rate, blood pressure, nothing exciting. But the heart rate, I mean, occasionally it does sort of go up to as close to 180. And this baby was needing, initially the SATs were fine, but then started to desaturate. You have periods of desaturation. So the baby was receiving 1 liter of nasal cannula oxygen, and they sort of managed to wean that down. But then you did have episodes of desaturation during those periods intermittently, and this baby was tachypnic actually. So serial blood gases showed lactate, which was normal, and this baby was admitted to the pediatric ward. So they did the entire workup, infection screen, everything was absolutely normal and negative, and this baby was happily breastfeeding, needing this tiny amount of oxygen. So they called me because I have another colleague who does, who's a pediatrician with expertise in cardiology, and she was on leave. So they called me as the only other person who could do the echo. So this was the X-ray that was done for this baby. Who was on a little bit of nasal cannula oxygen. So I did the scan, and this is what I found. So the subcostal view, I've got a bit of the atrium and the ventricles. Any comments?
Oh, you've got whale sign.
Whale sign. Oh, okay.
Well, it's right to left shunting at atrial levels, increase right atrial pressure, and you can see something coming into right atrium through coronary sinus.
Yeah. So what I found the most obvious is you have blue flow, isn't it, across the PFO or the intraatrial communication. So there is clearly an increased pressure on the right side. And you have pure blue flow.
And you can see
pulmonary venous
behind
return.
the left atrium.
Say that, Mahmood.
You can see something funny behind the left atrium. I'm not going to say what it is.
So that bit there. So when I was scanning, the blue flow made me worried. So then did the pressure. So I knew the right side pressure is high. So this is TR close to 5 meters per second, and there's a degree of pulmonary regurgitation, again close to 4.2. Apical 4-chamber shows a large right side. The left side is squished. The interventricular septum is deviated towards the left side. And this is the money shot. So this gives it away. So let me go through. So 2D picture, if you see, there is a blood vessel, a vessel that is coming right down into the liver parenchyma. The vessels in the liver look all dilated. And then if you look on the color picture, the 2D, so right at the back, so this is the spine there. So you have blood that is going towards the probe, So this, and it looks pulsatile, so that's the aorta. But then if you look at the second red blood flow, if you look at the profile, it is not as pulsatile as the aortic flow. So it has more of a venous profile. So you have a big vessel that is draining away from the heart. It is going into the liver. The blood vessels in the liver are all enlarged, and then you have blood coming back from the liver, going there, and the vessel that you see here, that's the IVC. It's joining into the IVC and it's draining into the right side of the heart. So this is, so what is this?
Anomalous pulmonary venous return.
Yeah, so it is absolutely, it's absolutely right. So it's an infra cardiac. So these are my echo findings. So right to left flow across atrial septum, enlarged right atrium, right ventricle, significant TR jet, and you have a descending vein. So this is an unobstructed infracardiac.
Luckily, yeah.
TAPVD. So this baby was referred to our regional center of Great Street and was repaired the following day. The 6 months follow-up, the baby's thriving, and 6 months follow-up echo showed an unobstructed pulmonary venous drainage. There was no acceleration, there was no residual atrial communication with good biventricular systolic function. And one of the things in TAPVD, obviously, when you look at TAPVD, is the vast majority, at least in this case series, which is looking at their 40 years experience. Supracardiac is most common, followed by cardiac, and then you have infracardiac, and then the mixed picture. And in infracardiac TAPVD, I was always taught that infracardiac TAPVD is universally obstructed. But yeah, it's about 75% you have pulmonary venous obstruction, and you have a small percentage who are not obstructed. So I was a bit surprised when I saw that big vessel coming down in this baby who was happily breastfeeding in a little trickle of oxygen. And that's something that I learned. So here, if you look at this, so this is supracardiac, infracardiac, cardiac and infracardiac TAPVD. So one of the things that I've learned is in TAPVD, you need to track this, either if it's the vertical vein or the descending vein, and follow it through. So if I just go to my case, that red vessel, which we saw going into the liver parenchyma, was this descending vein going into the liver parenchyma. At where it joins, you can have a bit of acceleration or blockage happening. So this is what you could see. If it is supracardiac, you'll obviously see from your parasagittal short axis, you'll see another vessel, which again will drain red and will drain into the innominate vein. Very common with the bronchopulmonary vices there, you can get obstruction there. And the cardiac, this is where you see the whale tail sign. So you come here and you see the sort of reds. Somebody had mentioned whale tail. So I haven't seen a case of cardiac, but I've seen supracardiac and cardiac. So studies have shown that if you have infracardiac PVD, so it is a significant risk factor for preoperative pulmonary venous obstruction, and the odds are 2.2. You need a very high index of suspicion in any of these babies who present with tachypnea and hypoxia with absent infection markers. I found it interesting, so I'd written up on it, and if you're interested, you can have a look. There are more pictures. But one of the things that I learned from this case was any baby with tachypnea, I mean, think of TAPVD, but when you think of TAPVD, don't think of the baby who's stuck on the ventilator, who's obstructed, who's very sick. You may sometimes very rarely come across a baby who's happy, feeding, may have just very little subtle signs. So that's why I wanted to highlight this case.
It's brilliant.
Thank you so much.
Very interesting cases, actually, and very elegant presentation as well. Thank you, Sujith.
No, thank you so much. Any questions or comments?
So it's just interesting. A lot of this infradiaphragmatic are ductus venous dependent circulation because they drain into ductus venosus. So when I was in Brompton in Cardiac Center, there were a few people who believe that the prostin weight keeps ductus arteriosus patent, potentially could keep ductus venosus, because these babies, when they go downhill obstructed, they just die because there's no intervention till they go to cardiac surgery and have an intervention. Did you come across any of a similar kind? I mean, obviously, they're different structure histopathologically. Ductus venosus is more flow dependent, as in flow keeps it open rather than any mediators.
No, so one of the things I know that when I have read that if you have infradiaphragmatic, especially if you're obstructed, a cautious use of prostin will help to dilate the ductus venosus, and it also is a vasodilator. It will help to vasodilate generally everywhere systemically, and you get slightly improved venous return. So, I mean, part of the thing is because you have compromised cardiac output because of your high right-sided pressures, you're getting D-shaping. So your cardiac output is anyway going to be reduced and systemic blood flow is going to be compromised. So, I mean, I haven't personally used prostin, but I know that in literature, there are mentions of using prostin to try and dilate the ductus venosus.
Yeah, we had a similar case recently. Probably Anne-Marie knows about that baby. It was a sad story. So it was a 36-weeker infant of diabetic, 1.8 kilograms, and the baby had low SATs. I might present it at one of the meetings.
Yeah,
But
please.
then on echo, noted obstructed infradiaphragmatic TPVD. When I phoned cardiology, obviously they wanted the baby over to them, but they said because of the size, that wouldn't be operable, unfortunately. So they have tried to stent the ductus venosus, but that wasn't successful, unfortunately, as well. I wonder if prostin might have helped, but they didn't consider it as an option. I know from literature that some people use it because ductus venosus, as a PDA, they do respond to prostin, but it's just probably only few cases reported about that.
I mean, histopathologically, the way you get neointimal quotients in PDA, you don't see oxygen sense, or those in ductus venosus. And speaking to a lot of fetal medicine guys, they just believe they are different structures, though they are called ductus. They have nothing to do with the mechanisms for patency of duct in fetal life are not the same for ductus venosus.
Yeah.
I think that's a good point, Mahmood, though, and it'll be a really I think it would be a good case to present it. It can be done nice and anonymously, to look at the pictures and think about it. I think we have tried prostaglandin in the past, and I think the papers, the literature out there is not terribly convincing, but it's a good point.
I guess it's desperation as well.
Yeah,
Exactly.
I suspect it just looked like in this case that actually really it just wasn't going to work out.
Yeah, just that baby was too small for any potential ECMO or anything, bypass for the surgery. So unfortunately, baby passed away.
Yeah, but it would be good to share the story and the pictures at least.
Yeah,
great.
Well, I've got quite a few interesting cases, so lined up. So keep tuned.
Excellent.
Any question or comments for Sujith?
Just for any term baby who is not unnecessarily, it's like many babies like with anomalous pulmonary venous drainage, usually even the partial non-obstructed, they just present with a little bit of oxygen requirements and some kind of mild respiratory distress, but it's not like correlating with anything. So it happened that I always ask for echo in those babies because I personally don't do the echo, and I think I had 2 or 3 in the last 6 years that became as anomalous pulmonary venous return. So sometimes it's mild, but it's not fitting with TTN or infection or anything. So it's always important to try to diagnose them.
I mean, also they escape our domain because typically it's in the first week, beginning of second week when they would come with murmur. So we have had, I mean, so far all we had at George's were PICU, none on the neonate unit.
I think it's a really good lesson to take home. It's easy not to echo them, and my goodness, it's so important.
Absolutely. Maha?
Really quick and simple question. Did this baby have SATs done in their postnatal examination? And
No,
must have been
no.
Yeah.
So
picked up then.
yeah, so I wonder. So we are a unit that we haven't adopted that practice. I know it's the National Screening Committee may come up with further recommendations, but we don't. But you're absolutely right. I wonder whether this baby would have been picked up had we done pre-postnatal SATs.
Yeah, I think it would have. Yeah.
I thought this is practice in all England, because I was a bit concerned when I moved to Scotland that we don't do a pulse oximeter test for part of NIPE. So definitely in the Northwest, everywhere we just we used to.
It's very varied, Umaima. 2-3 miles, we have another tertiary center that does it. So it is very varied within London.
I mean, we don't do it either, but our prenatal detection rates are highest in the country. And when we looked at our last 10 years, I think from the data, the team didn't feel. I mean, if you call it as a well-being screening tool, that was more sellable rather than a screening tool for congenital heart defect.
Yeah. Actually, I've seen some cases picked because of the community midwives. So they check the saturation also at home for the babies when they go home and being seen on the 2nd or 3rd day. So I thought this is everywhere, but
yeah, I mean, even the false positive who were well babies were not well, even though they didn't have a congenital heart defect, they had something else wrong with them.
Yeah.
So we're trying to push more as a well-being screening tool rather than critical congenital heart defect to try and bind.
If you allow me, just in the last 2 minutes, there was one case up. It will be nice to share it. So this baby was referred from a second level 2 unit. Term baby, required intubation because of respiratory distress, developed one-sided, I think was right side pneumothorax, was on all the inotropes you can imagine, dopamine, dobutamine, adrenaline, noradrenaline, referred to our unit, one of the units that I used to work, which was a tertiary unit, but not a cardiac unit or surgical unit. So baby was started by the transport on nitric and continued the nitric when he arrived to us. Actually, the nitric probably made things worse. You know, it didn't cause like a significant improvement. Baby was still on 100% oxygen. So anyhow, the saturation was like 90, low 90s. When I looked at everything, I found that this baby did have not relatively a bad start. There was no evidence of like high CO2. It just very high pressures were used and developed pneumothorax, and then, you know, like a cascade of series of deterioration. So I wasn't personally doing echo, and I'm still hopefully trying to develop that, but I had a huge, you know, suspicion about like there is underlying pulmonary cardiac condition. So the cardiologist, our neonatologist, another one like doing echo came, and it was anomalous pulmonary venous return. This was supracardiac, but was obstructive. And nicely, you know, the X-ray like typical snowman appearance. But just to the presentation, this baby just went on the right time for Lister for ECMO, and this baby has been saved. And it's one of the cases that I'm really, you know, like, you know, it gives me a lot of relief and not pride, but, you know, like satisfaction that we had this kind of index of suspicion. So sometimes we really need to also to dig, especially with the cases with element of apparently pulmonary hypertension not responding to nitric oxide as well. Thank you.
Absolutely, Umaima. That's a nice case. Okay, thanks, Sujith, and thanks.
Thank you so much for this.
Mahmoud, last question. Sorry. So, is it when you hear, because I have this idea in my mind, when you hear right to left shunt across the PFO, it's always pulmonary venous, or mean alarming. Is that right?
That's not normal. So when you see right to left through the PFO, it's TAPPD until proved otherwise. So when you do that and you see that on the echo, your hair should be up, and you just try to find something wrong in the echo, you know. Yeah.
Okay, thank
We
you.
picked three cases in the last couple of months.
Wow, okay.
Yeah.
Thank you very much. Okay.
No worries. Thank you, Sujith. And
And can I just say one last thing?
Yeah, Mahmoud.
Sorry,
Yeah.
Mahmoud.
Sorry, can I just, oops. One last thing just to respond to Umaima's question. Right to left flow through the PFO, as you all have said correctly, thank you, TAPVD or really nasty PPHN, which is what we're as neonatologists always thinking of first. And the problem with that is then you've got this right to left flow, you think the baby has PPHN, you look for your pulmonary vein, they're difficult to see, and you think, well, yes, in PPHN, the pulmonary vein venous return is so low. So you're then thinking, oh no, maybe it isn't. So unless you absolutely put in your brain, I need to have a pulmonary vein, at least one that I can see going into the left atrium with Doppler, with flow, then yeah, TAPVD. Because it's very easy to muddle those two up. And PPHN is so much more commoner, isn't it?
Yeah. Yes, thank you very much for highlighting this, because this was actually, I should have clarified the question. I mean, not in the context of course, after ruling out just severe PPHN, you know, and looking at the duct flow and everything. Oh yeah, I agree with you 100%. Thank you very much.
And just for all of us, TPVD is really difficult diagnosis. And if we're not sure, probably should give a shout to cardiologist because of the implications, obviously, of this case kind of being missed or anything like that.
Yeah.
Okay. Thanks, guys.
Thank you.
Thank you.
See you next week.
Thank you. See you. Thank you very much. Thank you.
Thank you.
Bye-bye.
Bye-bye.
Bye.